There are 5 things that really disturb me and concern me when it comes to addiction and addiction treatment, and I want to tell you about them now. It's the whole reason for this channel. By the way, the 5th one is what really makes me a heretic today, so you're going to want to stay tuned for that one. Um, the first concern I have is patient rights, and there is just not a lot of material available on YouTube or anywhere else on patient rights. When I think about exploited classes of people, vulnerable people, people who are preyed upon relentlessly, addiction patients are going to be the first ones that pop into my head. And what's scary, there's a lot of things scary about patient rights and the issues I have with them. Here's an example. When any client goes into virtually any facility that I'm aware of, they have an intake. And with that intake, there's a lot of paperwork involved. You have releases of information, you have to give permission for treatment, you have to sign the rules and regulations of treatment, you have to sign patient responsibilities, and you have to sign patient rights. The thing is, most facilities only give maybe an hour, hour and a half to do an intake, after the assessment. So the paperwork is thrust at them, and the patient is highly encouraged. Oh, go ahead and sign that. We'll talk about that later. It's just routine. That's just one of the many problems I have with patient rights. Finding the phone number to contact. Who do you contact if your rights are being violated? Here's the challenge for all the methadone patients out there. Who is your state opioid treatment authority? Who do you call if you're being taken advantage of, if you're being neglected, if you're being abused, or if your facility is just making human mistakes? Who do you contact? So that's the first thing that concerns me about addiction treatment, especially as addiction treatment tends to grow. Now, when it comes to exploited classes of people, it would be easy for me to say that there is no one more exploited than patients. Ah, you might be wrong on that one. The next class of people that I'm concerned deeply for is the counselors' rights. Counselors are subject to so many, I can only use the word horrifying. Um, I love methadone treatment. I've been a staunch advocate for methadone treatment since my second year in methadone. I'll have to do a video on that. So I have nothing against methadone as treatment for opioid, but what I do have a problem with is taking people off the street, getting them registered with the board so that it's legal for them to practice, running them through an in-doc period, giving them basic training, and then boom, giving them a caseload of 15 to 50 people, which as a program director, guilty as charged. Counselors in various facilities and modalities, not just methadone, they work through their lunches. They really don't have good pay. The hours are rough. The endless, mindless regulations coming from accrediting bodies, from state authorities, federal authorities, and the company's own policy and procedures, it's really it's really bad. Uh, I got a survey a while ago from one of the certifying bodies concerned about how many people are leaving the field. People are leaving the field because they're treated like crap, many times in violation of specific established federal employment law and state employment law. You get these empathetic leaders, right? Empaths who, oh, we're here for the family and we're here for the patient's needs come first. No, actually, when you have a burnt out counselor, you have a dangerous counselor. When you have an upset, angry counselor, you have a dangerous counselor. When you have a legitimately confused counselor, you have a dangerous counselor. So that's the second of the really big issues that I want to address. The next one is pretty broad, but right now there's a tremendous amount of groupthink in addiction. And this has a little bit of nuance here. Most of what you're going to encounter in addiction treatment, in my experience, and based on my reading, is actually mental health counseling. So it's looking at uh, common post-acute withdrawal symptoms, which would be anhedonia, not able to feel pleasure, depression, anxiety, sleeplessness. There's a tendency to view that through the lens of mental health treatment, where mental health treatment, what's the number one recommendation? Mental health treatment? Drugs. And if you're on drugs, then more drugs. That's a blanket statement, and it's going to get you into a lot of trouble, and there's a lot of nuance to it. But there's a tremendous amount of groupthink, especially under Nora Volkow with National Institutes of Health. It's like everybody is starting to think about addiction in the same way. And here's a brutal truth. This is the most real thing I'm ever going to say on this YouTube channel. Nobody understands addiction. What people understand, what doctors understand, what YouTube personalities understand, what clinical supervisors tend to understand is hopefully a theory, a point of view. Addiction, look, the easiest way I can put it is everybody is totally wrong about the causes of addiction, the course of addiction, what addiction's like, what everybody's wrong. At the same time, everybody's right. Right? So, whatever theory, whatever your approach is for addiction recovery and treatment, you have roughly, let's be generous, a 12% chance of it being effective, right? So basically, we're still throwing darts. They tried to do treatment matching with Project Match back in the late 90s, but I'd be surprised, how many counselors, how many clients, how many patients, how many of you all have heard of Project Match? Anyway, there's a lot of groupthink, and I'm seeing a lack of one, critical skills. I'm critical thinking skills. I'm also seeing a lack of fundamental, based on replicable science, actually, based on meta studies. I'm seeing a lack of stages of change theory. I'm seeing a lack of motivational interviewing. I'm seeing a huge lack of understanding of the effects of drugs. So here's a question. I ask this question of every counselor who doesn't have actually, I ask this question of everybody. It's one basic question that I use, and yeah, I'm judgmental and I'm assessing them. What are the withdrawal symptoms of cocaine? If you don't know what the withdrawal symptoms of cocaine are, if you don't know what the withdrawal symptoms of marijuana are, if you don't know what the withdrawal symptoms of alcohol and how they're all different, how can you possibly understand what the client is presenting? So I'm seeing a lack of that, and I'm seeing a lot of groupthink. That leads us into my favorite part of groupthink, which is medication for all and its very close cousin, mandatory involuntary treatment. I am a medically assisted treatment advocate. I have been in favor of medically assisted treatment since I first began this journey in 2006. I have seen remarkable things. You get the right patient with the right medication. And there was one dude, he had a 25-year history of alcohol abuse. He was literally the town drunk. This is a small town. Nobody in the world thought that he would ever be able to put together 2 days sober, let alone one. And the last I heard from him, he had like a year sober because Vivitrol actually worked. I am so in favor of that. I've seen impossible cases that would stump pretty much anybody, Aaron T. Beck, Freud, Skinner, that They gonna get on a correct dose of methadone, and all of a sudden they function normal. Like when you see them in the street, you can't even imagine that they at any point they were using drugs. So I'm really in favor of medically assisted treatment. What I'm not in favor of is getting people who meet criteria for a mild substance use disorder or even a moderate substance use disorder. Let me go all the way. Let me jump all the way in. I am not in favor of giving medication to people with a severe diagnosis who don't meet criteria for tolerance or withdrawal. Yeah. So right now, it's like, hey, medication's easy. It is sexy. It is in the news. I'm not saying you get rid of it. You know, there's a cognitive distortion, either or thinking. I'm not thinking either or. I'm like, hey, let's just dial it back a little bit and let's not be in such a rush to prescribe all these medications, which have side effects. They can develop tolerance and withdrawal to the. So, medication for all, maybe not so much. Lastly, and certainly not least, and this is related to all of it, my God, the obsession with dopamine. I mean, if you go on YouTube, if you search anything, I've got an app, right, that my client found. Good for her. By the way, I'm not going to shut them down. Man, if you get an app that is telling you that dopamine is primarily involved in alcohol use and it helps you get sober, okay. Okay. Like I said, everything works and nothing works, if that's what it takes. But seriously, you're any presentation that says that dopamine is primary on alcohol, totally ignoring GABA, totally ignoring, the actual primary neurotransmitter. I see this a lot in opioid presentations where, yes, opioids trigger a dopamine response. And yes, I get it. It's in the ventral tegmental pathway. Um, I get it. It's a reward. Dopamine's a reinforcer. It is not everything. Okay. Endorphins are primary to opioids. GABA is primary. There is one. Dopamine is absolutely primary with cocaine, but it's like the only one that is. I am extremely concerned with what I see as a single mechanism bias towards dopamine, which reminds me of the now debunked but used anyway serotonin theory of depression. We get fixated on one thing. We get fixated and it's sexy and it's popular and we can all write our material. We can do our YouTube videos and we can put up our PowerPoints and stuff. Dopamine, 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 dopamine. There's a lot of other neurotransmitters, including serotonin, acetylcholine, oxytocin, adrenaline, norepinephrine. I could bore you to tears, right? So those are my biggest concerns. Patient rights and how they're being violated, counselors' rights and how they're not even being considered, groupthink. We all find the new sexy thing that's all over LinkedIn, medication for all and involuntary treatment, which I barely touched on, and our obsession with dopamine. So that is a lot of ground to cover. So as I do videos for the channel, I'm going to try to focus on those, but it's a little bit like a treatment plan. Treatment plans are great, right? So this is my treatment plan. I'm going to address these 5 things, and then I'm going to do it with writing on Substack, and I'm going to do it with videos on YouTube. And then something comes up that's not on the treatment plan. Will insurance let you bill for that in a similar situation? I think not. That'll be another topic. So anyway, I'm Scott Spiers. I'm a licensed clinical addiction specialist and a clinical supervisor. I'm coming up on 19 years in the field. Is that true? Yeah, 19 years in the field, and I'm getting ready for retirement. So if you want to get more content like this, be sure to like and subscribe. It might be a bit early for my Substack, but I'll also be doing written material and more hardcore stuff, like the really controversial stuff that I have to do. That's going to be on Substack. But if you watch this long, one, thank you if you watched all the way to here. The other question is, what are you doing? Don't you have anything? This is just my wrap up pitch. Go, go do good things. Just come back later.